Welcome to the University of Michigan Dentistry podcast series, promoting oral health care worldwide.
When severe handicapping conditions, unmanageable behavior, medical or other problems are present among patients with severe dental diseases, management techniques become limited for the delivery of dental treatment.
The indications for the use of general anesthesia are the very young, immature patient with rampant caries, mental retardation, which prevents communication with the patient, physical handicapping conditions, which significantly limit positioning of the patient or which interfere with access to the oral cavity, emotional disturbances, which produce inordinately high levels of anxiety or fear, and patients for whom the routine methods of treatment and behavior management have failed. When general anesthesia has been selected as the method of choice to treat the patient's dental problems, hospitalization will be required, either on an inpatient or outpatient basis. Medical consultations will be required to evaluate the status of the patient's physical health and to determine if any significant anesthetic risks are present. Reservation of a hospital bed and scheduling of operating room time must be coordinated with the hospital admissions department and the operating room. Hospitals with live-in facilities for parents have the advantage of keeping a familiar person close to the child.
When a date and time have been agreed upon, the patient is escorted to the hospital and the following procedures are accomplished either before admission or at the time of admission. Physical examination, including dental history, medical history, and systems review. Consultations with other medical or dental specialists as indicated. Initiation of laboratory studies. Hemoglobin, hematocrit, white blood cell count, urinalysis, chest x-ray, and dental x-rays when possible. Admission orders, including medications, diet, oral care, and activity on the ward. Consent for the dental procedures and the use of general anesthesia. Anesthesia evaluation, which includes a chart review, instructions to the patient or parent, and orders to prepare the patient for general anesthesia. Upon arrival at the operating room, the dental team should be prepared to receive the patient and assist with patient transfer to the operating table.
The induction phase will begin with the patient on the ward cart. This 12-year-old boy with Down syndrome was brought to the operating room to receive a general anesthetic for dental treatment. General anesthesia was indicated due to mental retardation and severe obstructive behavior previously demonstrated in the dental office. This patient received preoperative sedative medication 1 hour before entering the operating room. An intramuscular injection, 80 milligrams of seconal, was given for sedation. In addition, 3 milligrams of morphine sulfate was given IM for relaxation, post-operative analgesia, and to potentiate the sedative effect of the seconal. These drugs and dosages were chosen based upon the patient's health history and body weight.
Oh, what a good boy. What a good boy. Oh, you're such a good boy. Oh, you're such a... No, Eddie. No, Eddie. No, Eddie.
Notice that despite careful premedication, this patient requires some physical restraint by those assisting the anesthetist.
That's a good boy. Good boy. Oh, yeah. No, it's fine, Eddie. Oh, no, it's just fine. That's a good boy. Such a good boy. Oh, yeah. Oh, Eddie, such a good boy. Such a good boy. Oh, good. Getting a little sleepy. Oh, it's okay, though. I'll hold you. I'm gonna hold Eddie.
Inhalation of a gaseous mixture of an anesthetic agent, in this case fluothane with nitrous oxide and oxygen, will render the patient into a state of light anesthesia. This method of induction was chosen because it requires a minimum of patient cooperation and can be accomplished very atraumatically. As anesthetic induction begins, the patient's eyelids close and the torso relaxes, while the anesthetic mask is held firmly in place over the mouth and nose.
I got that real nice one right there. I'm going for a 3-shot now.
Oh, Julie, that's just...
I don't know, but it's good.
Go.
The patient is then transferred to the operating table in the supine position by several assistants. A blanket is used to cover the torso and extremities to minimize heat loss from the body during the general anesthesia procedure. Initially, EKG leads are placed on the upper torso to monitor heart rate and rhythm. A plastic airway is placed to assist breathing.
Ooh, everything is just try to do this. You're going to try blindly? Yeah.
A stethoscope is utilized to listen to both heartbeat and respirations. A towel is used to wrap the head, protecting the patient's hair. IV puncture is begun in preparation for the administration of pharmacological agents necessary to accomplish nasal endotracheal intubation and for the purpose of fluid replacement during the course of treatment. Intravenous fluid replacement and maintenance is required because the patient receives nothing by mouth for 8 hours prior to the administration of general anesthesia. Additionally, fluid maintenance helps prevent a decrease in blood pressure caused by vasodilating effects of the anesthetic agent. Finally, the fluid facilitates the administration of intravenous drugs. The IV fluid is a normal saline solution with 5% dextrose in water. This provides the patient with calories and fluid volume compatible with the blood.
Give you the drug. Oh, thank you. Remember, this is color TV. Oh. Yeah. Sure.
needle and tubing have been stabilized with tape, an arm board is taped to the patient's forearm and hand. This prevents accidental dislodgement of the IV needle during the procedure or the recovery period.
And not pull the IV out.
I got it.
Okay, one. A little longer, I hope.
Isn't that long enough, Maggie?
A blood pressure cuff is applied to monitor blood pressure throughout the procedure. At this point, the first injection is administered. Robenol, 0.2 milligrams, is given IV to dry secretions and block vagal responses stimulated by intubation. Uncontrolled, these responses could produce hypoxia and subsequent bradycardia. A topical application of 4% cocaine solution will be used to anesthetize the nasal mucous membranes and produce vasoconstriction to minimize epistaxis. A powerful muscle relaxant, 30 milligrams of succinylcholine, will be administered IV just prior to intubation to relax the vocal cords, allowing a tube to pass easily into the trachea. Cotton tip applicators are used to swab the nasal passages with the cocaine solution.
We're going to try for the, okay, what do you think? Okay, that's kind of big, huh? Oh, sure. You want the straight leg? Yeah.
The nasal endotracheal tube has been selected and placed on the patient's chest in a sterile gauze containing lubricant. The patient is perfused with 100% oxygen just prior to attempting intubation because succinylcholine paralyzes the patient for approximately 90 seconds. The cocaine swabs are removed and the left nostril is selected for the initial attempt at nasal intubation.
Did she give the neck to you?
Once the tube has passed through the nose and into the posterior pharynx, its proximal end must be directed between the vocal cords. The lighted tip of a laryngoscope can illuminate the back of the throat, allowing the anesthetist to visualize the cords. The curved blade of a laryngoscope is used to retract the mandible down and forward, with the tongue held against the floor of the mouth.
It'd be nice if they just slip right in for me, but they're not going to do it today.
A McGill forceps is used to grasp the proximal end of the tube and position it over the opening between the cords. Downward pressure is provided by the anesthetist assistant pushing on the distal end of the tube, forcing it into the trachea. Quickly, the lung fields are checked to be sure both lungs are being inflated. If the lungs are not being inflated, then the tube has most likely passed into the esophagus and must be repositioned. If only one lung is being inflated, then the tube itself is blocking one of the main bronchi and must be retracted slightly to allow inflation of both lungs. When adequate respiration is confirmed, all other vital signs, including blood pressure, heart rate and rhythm, and temperature, are checked to be sure the patient's condition remains stable.
We're just going to do a little tinker around here, is that the thing? Take this baby so it never moves, huh?
Yep.
Eyelids are
Cover the
taped
corner.
closed to keep the eyes moist and to protect them from debris that might land on the face during the course of dental treatment.
What kind of tape do you like for this?
Tape is applied to the nasal tube and securely placed over the skin of the cheeks previously prepared with tincture of benzoin. This helps prevent accidental repositioning or dislodgement of the endotracheal tube.
Okay, good thought right now. Right now, I think you're right.
The airway and entire head drape are secured in place with 2 long strips of 1-inch adhesive tape.
Okay, now let's put a little...
Notice the head turban previously placed to protect the hair and ears. Careful protection and stabilization of the head and airway will allow the operator greater access to the oral cavity and the operating team a greater margin of safety.
And the ears are okay, right? Yes, they look flat.
I need the gloves, though. To minimize exposure to radiation, the anesthetist, operator, and patient are protected with lead aprons while dental films are exposed. In addition, the operator will use lead-lined gloves to protect his hands from direct exposure, since the patient's jaws must be held shut for him.
Yep, got it.
The green light on the side of this portable X-ray unit indicates when the machine is operative. A full-mouth radiographic survey is often required in the operating room because of the poor level of cooperation obtained from these patients in the office. The severe obstructive behavior, which serves as one indication for general anesthesia, frequently precludes the acquisition of an acceptable radiographic survey in the office setting. The initial maxillary anterior occlusal radiograph is taken with the airway disconnected for approximately 10 seconds. A team of 3 can operate most efficiently to take radiographs. A typical series of 8 films, including 2 anterior occlusal views, 2 bite wings, and 4 periapicals, should not take longer than 6 to 8 minutes.
Does it look okay on the teeth? Okay. Good, looks good. X-ray?
Disconnecting the airway for 10 seconds is quite safe. If the patient is breathing on his own, then a 10-second interruption in anesthetic gas will not interfere with the state of anesthesia. Similarly, if the breathing is supported, then a 10-second interruption in breathing will have no deleterious effect whatsoever, as this is much too short a period of time for the patient to experience any oxygen debt.
His tongue in there.
I know.
Okay.
Better. You're angled up rather than down, so.
Yeah, we gotta get.
Good.
That's too severe.
Is it?
Yeah.
Okay, you said it.
Notice that the orange light on the head of the X-ray unit flashes on during the exposure time to ensure the operating team that the films are being exposed.
You got the other one there. There you go. How's that look to you? Does that look pretty good?
A little steep.
A little steep? Okay.
Yeah, it's pretty good.
Okay. X-ray?
That's the last X-ray.
Okay. Thank you.
The operating team, consisting of the dentist and his chairside assistant, will be seated at the head of the table. the instrument tray will be positioned within easy reach using a Mayo stand to support the tray over the patient's torso. The chairside assistant's primary function is to maintain a clear, dry field for the operator and assist with the retraction of soft tissues when necessary. Notice the anesthetist recording vital information on the anesthesia record concerning the patient's condition and drugs administered. The dentist and his assistants will wash their hands using clean technique. Gloves and safety glasses are used to prevent cross-contamination and accidental injury to the eyes. At this point, the patient is draped and instruments and equipment are prepared for the dental operation. A second assistant will oversee the operation of all mobile equipment and prepare all instruments, handpieces, and materials to be utilized in the course of treatment. The throat pack will be placed prior to any intraoral procedures. Initially, scaling, oral prophylaxis, examination, and a treatment plan will be accomplished. All indicated restorative procedures will be completed next, followed by a topical fluoride treatment. Oral surgery procedures, usually simple extractions, will complete the dental operation. At the conclusion of treatment, the throat pack will be removed, extubation accomplished, and the patient transferred to the recovery room. In recovery, the patient will continue to have all vital signs monitored closely for 30 to 60 minutes, while supportive therapy assures the patient's rapid recovery from general anesthesia. A Molt mouth prop is used to facilitate the placement of a throat pack. A single strip of 1-inch gauze soaked in sterile saline solution to prevent abrasion and irritation of the soft tissue structures in the posterior pharynx is placed initially with a Kelly forceps. In this position, the pack will prevent the accidental ingestion or inspiration of foreign materials which might otherwise lodge in the back of the throat during operative procedures.
I need a little suction before we go any farther, okay?
Suction is employed throughout the packing procedure to remove all fluid from the throat.
Okay, I want to cut it.
Final placement of the pack after it has been cut should be done with the forefinger to prevent laceration or bruising of the soft tissues and to determine by palpation the adequacy of the packing. The pack fits snugly between the right and left faucial pillars and behind the soft palate. Once the throat has been packed effectively, dental treatment may safely begin. The Molt mouth prop remains in place to hold the mouth open for all intraoral procedures. Scaling of the teeth to remove hard deposits initiates the dental treatment. Notice the sequence of events designed to minimize wasted time and effort. Scaling is completed in both the maxillary and mandibular arches on the right side of the mouth before proceeding to the left.
We got all 4 hands facing.
Push them together so you get an air water spray.
Beautiful. Right. Let's see, suction in the back of the throat. Great. Good.
When scaling is completed on the left side, the polishing procedure begins on the left and again is completed in both arches before switching to the right side. When switching the Molt mouth prop from side to side, the tongue, which tends to protrude abnormally due to displacement by the throat pack, and the lips must be carefully protected to avoid pinching them on the occlusal surfaces of the teeth. chart, Paul? The oral examination will proceed in a pattern similar to scaling and oral prophylaxis. This method reduces the mouth prop switches to a minimum and allows the most efficient use of time possible. Any reduction in the overall anesthesia time will increase the safety factor and hasten the patient's recovery from general anesthesia. Due to the nature of the patient's behavior, this may be the first time that a complete and thorough oral examination could be accomplished. Examination and charting are completed on one side of the mouth before proceeding to the other side.
21, 2, 3, 4. Okay?
So the mandible is bilateral.
That's correct.
Radiographs are examined and a treatment plan may now be formulated.
I'm going to put both clamps on
Yeah, same time.
and then
The
slip it
operative
over.
phase of dental treatment begins with isolation of the teeth using a rubber dam. Rubber dam isolation provides the operator with maximum access and visibility to the operating field. Rubber dam isolation effectively retracts
that
soft
right in
tissues
there where it is.
and provides a reservoir for fluid and debris to collect. This added protection of the patient's airway is greatly appreciated by the anesthesia team. Conventional quadrant isolation can be employed. However, it may be more efficient to isolate an entire arch.
I'm going to do 3 and 30 first.
Another alternative rubber dam isolation
we can do it.
technique is utilized here to isolate single first permanent molars in opposite arches with the same rubber dam. Here we see an alternative method of ligating anterior teeth, providing maximum control and retraction of the soft tissues. Note that these alternative methods of isolation may be uncomfortable or difficult for the patient to tolerate if awake, and should therefore be used mainly for patients under general anesthesia. The equipment which the dental team brings to the operating room should be very mobile. The mobile unit containing high and slow speed handpieces and air-water syringe is powered by either a self-contained electric motor which produces sufficient air pressure or a nitrogen tank to provide direct gas pressure for the air-driven handpieces. The suction equipment is contained in a mobile cart and the vacuum is created by an electric motor.
All right, let's take this off. Just flip it over and dry it. Okay, going to use the same thing.
Notice the operator informs the anesthetist about the local anesthetic to be used for infiltration.
Hold that for a second. H and J.
H and J,
All right.
I don't think we have to use any
The administration of a local anesthetic is done for simple extractions, primarily to control hemorrhage. It is important to achieve adequate hemostasis in a short period for a patient under general anesthesia. For this patient, approximately 2 milliliters of 0.5% xylocaine with 1 to 200,000 epinephrine is used for infiltration. A lower concentration of epinephrine is chosen because a patient receiving fluothane is sensitized to cardiac arrhythmias from the administration of epinephrine. Therefore, the lower concentration allows a greater margin of safety and the dentist may anesthetize more teeth.
6/10
The local anesthetic is administered 8 to 10 minutes before the planned extractions. The vasoconstriction is better after a wait of this length. Having completed the necessary restorations on the right side of the mouth and the administration of local anesthetic for extractions, the rubber dam is applied to the left side, again with a double clamp. Efficiency is important in providing dental treatment under a general anesthetic. The efficient use of time is imperative to minimize anesthesia time. Consequently, it is important that the operator develop the ability to think several steps ahead in his procedures. By allowing the assistants to prepare equipment and materials in advance, the dentist will not have to wait unnecessarily. The dentistry may proceed at a rapid pace without rushing or hurried confusion. Notice the assistant in the lower left-hand corner mixing Dical while the field is being prepared for the application of this medicament. Likewise, varnish is prepared and applied while the restorative material is being mixed.
Looks good, Josh.
Got all the steps done now?
This series of procedures, from die-cal to final carving and burnishing, should flow continuously without any stoppage of action in the operating field. Notice that the isolation of teeth in opposite arches with a double-clamped rubber dam has provided a clear, dry operating field throughout the procedure. Excellent retraction of soft tissues by this isolation has provided the operating team with an additional margin of safety and allowed the maximum use of time.
We have got flash on here. Now we want to. I could probably use a bit more fluoride.
You need some more?
Yeah.
Yeah, a bit more.
A 1.23% acidulated phosphate fluoride is applied topically to all teeth prior to extraction procedures in order to have the mouth as clean and dry as possible. The effectiveness of a topical fluoride treatment at this point is enhanced by the fact that the patient's secretions have been dried by the Robenol.
And when you do your final finish, you look the same. It doesn't make any difference when you do a top.
Okay.
At this point, the extractions will be accomplished beginning on the side of the mouth where the fluoride treatment was completed. Teeth in both arches are curetted and then delivered with forceps.
So you can get both of them out. Okay.
You want the curette done?
No.
Lower forceps?
Yes.
Are you ready?
Extractions, similar to the examination, restorative, and preventive procedures, are accomplished with no wasted motion. All instruments are used until their function is no longer required and never used twice in the same sequence. Repetition of instrument exchange is to be avoided if possible to save time and effort.
Thank you.
They're finishing up.
I'll do the upper lower first.
We'll do the upper first.
As the extractions are completed, gauze pressure packs are prepared to control hemorrhage prior to extubation. The operating team must check to be sure that the oral cavity is clear and free of fluid and debris.
Dana?
Okay. You have that large pack with the
Yes, right.
string on it, and we're all set. He's ready to wake up.
Let's look at your extubation.
Next, the throat pack is carefully removed with a Kelly forceps. Notice the condition of this single strip of gauze. The distal end is stained with blood and small particles of debris. The proximal end is clean, indicating that the pack was effective in preventing the inspiration or ingestion of any blood or debris. A pair of 4x4 gauzes, folded and tied with dental floss to allow easy and quick removal, are placed as mechanical pressure packs to control hemorrhage from the extraction sites.
Bucking for the camera.
Immediately following removal of the throat pack, the anesthetist will examine the throat using the laryngoscope.
It looked pretty dry.
She will suction the throat free of any debris from the operation which may have lodged behind the pack.
Can you see?
At this point,
use
the
the
patient is
smaller-
recovering from anesthesia. All anesthetic gases have been stopped, and the patient is breathing 100% oxygen.
Conveniently located here.
Paul, pull the down, pull the down light out.
I've got him on 100%.
Yeah, we got it.
Still have my 2%.
Yeah, pull that out.
Yeah, can we do that? Look, see, and
Extubation is accomplished when the throat is clear of debris and secretions, and the patient has adequate spontaneous respirations. Extubation is done at the moment the patient's lungs are inflated, so that the first breath after the removal of the tube will be an expiration to help cough up debris and secretion from the lungs. Notice the anesthetist's hand position on the mandible, elevating the jaw and preventing the tongue from falling backward into the throat, occluding the airway. The anesthetist will occasionally assist shallow breathing with positive pressure on the bag. Vital signs are checked to be sure that the patient's condition remains stable following removal of the tube, especially adequate ventilation of the lungs. The ward cart is positioned alongside the operating table. The table is brought up to the level of the bed prior to transfer.
I'll get all the hot.
The patient is transferred to the ward cart in preparation for transport to the recovery room. Notice that the IV is maintained until the patient can take clear liquids by mouth, and in case additional drugs should be required during recovery. The patient is positioned on his side to prevent the inspiration of secretions or vomit. Blankets are again used to cover the patient for warmth.
A 5.
The acronym PARU stands for Post-anesthetic Recovery Unit. This recovery room is designed for patients who are expected to have either minor or no complications recovering from their general anesthetic. The patient will remain under observation in the recovery room for 30 to 60 minutes before returning to the hospital ward. Initially, a cold steam mask is attached to the patient's face to help re-moisten the lungs, which tend to become dry from breathing an anesthetic gas such as fluothane.
One of the dental students outside that door. Okay. To keep people from coming in. All right. Yeah, these two guys.
A blood pressure cuff is applied, and all vital statistics concerning physical condition in the recovery room are recorded on the patient's chart.
Post-operative orders must be written before the patient returns to the hospital ward or is sent home. These orders include medications, diet, and oral care instructions, plus any other instructions suggested by medical consultants.
If the patient is to remain in the hospital overnight for observation, the dental service will check the patient on rounds and write discharge orders the following day. If the patient is managed on an outpatient basis, the anesthesiology service discharges the patient when all vital signs are stable. In this event, 2 adults are required to assist the patient in leaving the hospital.
At the time of discharge, the parent is given written instructions and prescriptions which pertain to the patient's home care. A recall appointment is usually scheduled 2 to 4 weeks postoperatively to check healing and the condition of all restorations. Polishing of the restorations and repetition of the topical fluoride treatment may be attempted as some of these patients become more cooperative after hospitalization and relief of pain.
Finally, 2 documents are added to the patient's record. An operation report is dictated, which describes in detail what was done for the patient in the operating room. The final document is a narrative summary, which reviews the entire hospitalization from admission to discharge. The student may refer to a hospital dentistry text or manual for the details of this and other documents found in the patient's chart.
In summary, we have seen general anesthesia administered to a 12-year-old boy with Down syndrome for the purpose of completing all dental treatment at one time. The actual operating time was approximately 1 hour. All patients are scheduled for recall on an outpatient basis. To avoid future hospitalizations, attempts are initiated to maintain the health of the oral structures in the routine clinical setting.
No tooth count. Okay, I'll tell you what he's got. He's on the right side. The only tooth that he has, the only primary tooth that he has is T.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.